Oh, welcome back to the second session this morning. I'm Robert Sprouse. I'll be the moderator for the next few talks. We're running a little bit behind, so we're going to try to press forward here. Our next speaker is Dr. Mike Apley. Mike has a DVM as well as a PhD in physiology pharmacology. He's a diplomat of the American College of Veterinary Clinical Pathology. Okay, is this better? Okay, thank you. Dr. Mike Apley is a veterinarian with a PhD in physiology and pharmacology. He's the diplomat of the American College of Veterinary Clinical Pharmacology. His practice background includes 2 years in general practice in central Kansas and 4 years in a feedlot consulting and research practice in Greeley, Colorado. Mike was on faculty at Iowa State University for 9 years. He's currently a professor in the Department of Veterinary Clinical Sciences at Kansas State University. He works with veterinarians and producers throughout the United States concerning the use of drugs in food animals, and is also in the area of beef cattle health and emphasis on feedlots. He's a recipient of numerous awards. He is very entertaining and informative. Mike?
I'll take that in a positive manner, Robert. Thank you. It always makes you wonder when they ask you to give a talk and part of the title is what it isn't. And you wonder if they've sat through some of your other talks. So I get the opportunity to try to frame BRD a little more and maybe throw some things out there. And in this talk, I refer to some talks later on in our meeting that I'm very tickled to see and looking forward to hearing. So I think it's fair to say is BRD is not a disease with well-defined prognostic indicators. And this is a friend of mine that worked at a feedlot that we visited when I worked with Dell back in 92 to 96. And I keep this picture and I look at it. He's really good, a lot of cow sense, a hard worker. And a lot of the same questions we had about what we're treating, I think we still have today. So, 20 years later, we still have those questions. And so what are we doing to struggle through prognostic indicators? And so we have a lot of challenges in trying to define this disease. We have difficulty prognosticating morbidity in individual groups. We can talk about high-risk calves and we can place risk factors on them, but when it comes down to actually walking into an individual potload of cattle and loading at a feedlot, we still have trouble laying a really clear prognostic thought process into that group of cattle and saying this one's going to give us 20%, 40%, 50%, and it's multifactorial. We still struggle with that. An individual case outcome, we can look at overall numbers and talk about case fatality rates, etc. We have rules of thumb rates we talk to students about. But still, on an individual case, if it's slab-sided, leaning on the chute, and a 98-degree temperature, that one we can all pretty much get. When you start bringing them in as groups and start talking about potential case fatality and treatment success in a group of calves 106 to 107 versus ones 104 to 105, yeah, when you look at the long-term big picture, probably something there. But individual animal, we still search for that holy grail. We're going to talk a little bit more about individual case diagnosis. I mentioned in my paper that the time we're most sure of the diagnosis is when we're not going to be checked on it, right? So we can wax poetic at the chute about what that thing was, and if it got better, you guys know the drill. And so field outcome evaluation is also that's a challenge, and I like to listen to Dr. Engler talk about, the challenges of looking at their data without negative controls. And the thing I'm becoming more and more aware of as I look at treatment outcome data, case fatality data, etc., is we have to be extremely careful about taking field percent success data, case fatality data, and attributing that to a specific causative factor, whether it be the drug, whether it be we did or didn't use this vaccine. And again, I think there couldn't be a group that would be more aware of that. But still, when I see a trend or something that agrees with my bias, I like it, right? Okay, we're all human in here. So that's one of our shortcomings. And then the other deal is how much of the total picture can we see? It's a big element, a big elephant. We've all got the blindfold on. We're feeling around the legs. We're trying to figure out what it looks like. We're hampered by the fact that there's a pretty good breadth of work, of data out there that never sees the light of day. There's some generated within systems. There is not an insignificant amount of equivocal or negative data that just gets parked. Okay? Unmarked graves near Mount Sunflower in western Kansas. Okay, the only mountain you're on when you're not quite sure you're on it, but we still call it that. So that's a big challenge for us. So what about calves on the cow? And we're going to have some presenters involved in some of these data. I've read these, and rather than going into a summary of them and have to have the presenter spend 10 minutes correcting my analysis, I'll just say that both of these are excellent studies, and they both look at overall causative factors on the herd and things that are correlated, associated with, very informative. But still, when we come back to that individual animal, we're still struggling for the individual animal, which one's more likely to light up with BRD compared to others. In the feedlot, this was a really nice review across a lot of papers by Taylor and Fulton and everyone else involved in that in 2010. Positive association with sale barn purchase and commingling. Okay? I think a lot of us would look at that and nod our heads. Less consistent associations for shipping, weather, arrival weight, gender, castration, and dehorning. I agree with Mark, it's a lot better to have those done before they get to us. But when you actually go out and look for clear associations, it's harder to make. And what that points to me is this is such a multifactorial, tough thing to sort out. Again, I like the concept of it's multifactorial and there isn't just one thing we can fix. So this one again agrees with how I'm looking at it. So let's look at actual diagnostic attempts. And I really like it when people zero in on things in studies and go to the effect that give us information on how they work. And lung biopsies, ultrasounds, RFID-associated thermography, breath biomarkers, serum haptoglobin, rumen temperature boluses, pulmonary auscultation, rectal temperature, neonatal scoring systems, which we're going to have talks on later. Some of those authors. We're going to hear from about auscultation here from Dr. Knopfsinger following me. So keep it up. I mean, we continue to look for one thing that really trips the trigger, but maybe the more we have that we can put together to give us prognostic indicators, it's great. And again, I'm really looking forward to some of the talks on these and sharing with us what they're finding, especially against control data. So what about diagnosis? Here's something I advise you never to do. Never do a study where you put your clinical score on it, do the temp, and then have the lungs laying on the table 4 hours later. Let me rephrase that. Never do that and expect the feedlot to ever want you to pull cattle again on that premises. It's pretty humbling. So I'm not going to play the videos today. Some of you may have seen this presentation, but we did that. Atlanco was kind enough to sponsor us to do a study where we took 15 calves immediately after we said they are sick. Sale barn calves hauled from Arkansas up to northern Kansas. And then we also did 5 controls, untreated controls that, well, none of them were treated, and the 5 controls were normal thermic, below 104, and they were normal clinical score of 0. And so we compared these lungs, and so this one, there's his lungs on the left, and there's nothing there. It looks like a little something there, but it's not on histology. There's his right lungs. And so when you look at his outcome, I'd scored him a 2. He had 104.7. It was a December day that was 8 degrees Fahrenheit with a north wind. Okay, and for a Kansas boy, that's cold. I know those of you living further north, the girls are out selling Girl Scout cookies and shirt sleeves, but in Kansas, that's dang cold. The way that table's split up is I would look at the lungs and do grossly normal or consolidated. So here's the grossly normal, and there's right cranial, right middle, right caudal, accessory, cranial, left cranial, and left caudal. And so everything I saw in that animal, I said, that's normal looking lung. Histologist agreed on a 0 through 4 scale, put a 0. We were able to isolate Mannheimia hemolytica from the trachea, and Scott McVeigh was doing the microbiology workforce when he was in Nebraska. And we got no bugs out of the lungs. It's 1047, clinical score of 2 on a 0 to 4 scale, 4 unable to rise, 0 normal, 1 through 3 gradations. And so that's what the lungs look like. Here's animal number 2. It was the first calf off the truck, bright and alert. And Tuesday was the first day we pulled cattle. They had come in on Saturday. Bought on Friday in Arkansas, came in Saturday. So let's look at this guy. There's his right lung. You've got just a little bit of consolidation starting up there. That's just a blood clot on the left lung, nothing there. So very little lung, grossly affected. And the histologist said what I was calling grossly normal, had some early changes. I was able to get 36 grams out of that animal, total lung that was consolidated. And again, we got no bugs anywhere out of that animal. They weren't up enough where we were able. And these were getting straight to Scott as soon as we could get them to him. So that's now here's one that's I turned away from it the first time because I try not to pull ugly, and this one was not gifted with state fair kind of looks. It wasn't his fault. It's just kind of the way those things happen. But the rule is the second time they draw your attention, they need to come out. Out he came, and there's the left lung, so pretty significant down in here. The whole caudal portion of the left cranial is affected. Right lung, nothing going on. That one had, we got M-heme out of the tonsil, and we got a little M-heme out of the animal, about 9 times 10 to the 6 total count, out of both grossly normal, most of it out of grossly normal looking accessory lung. Then you can come to one like this. Here's animal number 12 on the next day, Wednesday. So there's a real head hanger. That was scored a 3. So now you start looking at that lung. There's caudal left cranial and really significant involvement on up here, all in the right lung. And this one we got M-heme and P-malt. It temped almost 107, scored it a 3. And we had significant findings of bacteria all throughout it. So what this one really did to me was show that we have, or I guess the word I'm looking at, reinforce that we have drastically different goings on inside the animal. Even within the same clinical scores, even with temps, things can be really, really, really different. So this study to me just underscored our challenge with diagnosis. So when we look at studies, some of our diagnostics or our case definitions, even though they can be as dialed in as possible, we still have these kinds of variations, which I think everyone does. Now, one thing BRD does have is, I would argue, the widest array of negative controlled clinical studies of any disease in either animal or veterinary medicine, or human or veterinary medicine. I would argue that there's no other disease that has this much negative control therapeutic data. Absolutely unsurpassed. And I like to, at these one medicine deals, get your arm around an MD and go, well, show me all your negative control. Oh, wait a minute. You can't even dose on a milligram per kilogram basis. So maybe you don't have any. So therapy of BRD, when we look at these negative studies, if we take 30 studies for about 23 different drugs across Freedom of Information summaries, good clinical practice, pivotal studies for drug approval, what we find is that the treated response rate for success, and these are maybe the longest is a 56-day study, but a lot of these are 28-day studies, so there could be some failures on out there. But our treated response rate, according to those criteria, 51 to 92%. Control response, 0 to 57%. If you convert that to how many calves do I need to treat with an antibiotic to make a difference in one, it comes out to about 2. These would be high-risk calves. About every other calf you stick a needle in, you make a clinical outcome difference according to the clinical definitions used in these studies. Pretty impressive stuff. So if you look at that from the 30,000-foot view, the blue line is the response rate in the untreateds. The red line is the response rate in those that are treated. The green is the difference. So these are the ones that would be successes in both groups. These would be the increased successes in the untreated group. And then the yellow are the failures. So if you look 30,000 foot, what does BRD do? Well, there's our overall response rate we'd see if it was out in the field and we were just looking at what % of our animals are successes. Look at the difference between those drugs and studies on how much of that apparent success rate was due to ones that would have got better anyway versus ones that the drug made a difference in. See how that moves all over the place? A lot of variation. So overall, I'm pretty comfortable that if we're treating high-risk calves, every other one we put a needle in, we probably make a clinical outcome difference in. An individual animal or even a pin, I have no idea what we're doing. Okay, what real true difference we make. Case fatality. What about case fatality? How many of us would like it so that every animal we treated, we lost none? I'm glad to see no hands go up because I think that's unattainable, and if we try to achieve that, we're going to treat way more than we should be treating. One of the things we're going to have to become comfortable with on all levels of veterinary practice is the same thing they're going to have to go to in human practice. We're going to have to be comfortable that the optimal application of antibiotics involves getting into some of them a little later than we probably should have. We're going to have to live with that, I think, to avoid just plain old over-application. So what are the things that cause us to look for balance in case fatality? Obviously, we're not treating them for free. In this last year and a half, the cost of treatment to the value of the animal ratio has changed dramatically, which makes us tend to overlook that a little bit. We're trying to conserve those animal resources. Animal welfare is a huge issue. Labor to do it. And then antimicrobial exposure in a population. So those all figure in. So what's case fatality look like? If we didn't treat high-risk calves, how many would die? Okay, if they were diagnosed, how many would die? So only 21 of those 30 studies reported mortality. In the treated animals, our mortality went from 0 to 23%. For controls, 0 to 48%. Basically, every seventh calf we treat, high-risk calves for BRD, diagnosed according to these case definitions, we prevent a dead. About every seventh one. If you look at this, how many die if you don't treat them? 4%, 6%, 6%, 7%, 6%, 2.5%, 12%, 36%. Our highest one observed in these studies was 48%. Now, we can argue about case definitions. It's probably a little harder to argue about dead or alive. Although in this room, you give us an hour closed-door session, I'm sure we could make it. I'm sure we could argue about that. Okay? We'd find someone. But that's your answer on how many die across these studies if untreated. And so back again, what difference does it make? The top of this chart is only 60% again, but there's the difference it made in case fatality. So again, across these studies and across drugs, huge differences in case fatality rate across these. I am comfortable saying that if we are treating in a group of high-risk calves and we see a 30 to 50% case fatality rate, that is a case fatality rate that is very similar to the untreated controls in these studies. I have a hard time thinking that the drug is making what difference it can if we're seeing a 30 to 50% case fatality rate repeatedly. Control of BRD. What difference do we make there? So these were 7 FOI documents, Freedom of Information documents, 2 publications. Basically, when you go through all those numbers, every 5th calf that a needle was put in at processing, in those studies, a case of BRD was prevented. So if you carry around 2, 7, and 5, every second calf we treat, we prevent a treatment failure. Every 7th calf we treat in these studies, we prevented a dead. Every 5th calf we treat for control of BRD, these studies would suggest we prevent a case. And as Mark mentioned, the data's rock solid on that. You go looking at those, here's the same presentation. On your left, these are the ones that, and again, now we've switched where this is not good instead of being good. So these are the ones that got sick in both groups. Here's the difference that was made by the drug, and these are the ones that did not get sick in both groups. So you can see the difference in the morbidity challenge in the untreated animals, and then the difference that the drug made. And again, wide difference in effects as you go across there. Now I'm going to try to very carefully state this next statement because it's very important. I predict that in 5 to 10 years, and if I'm wrong on the timeline, that in 5 to 10 years, a majority of the supply chains will no longer accept antibiotics for the routine use to prevent disease. I'll restate that. Mike's prediction. 5 to 10 years, majority of supply chains will no longer accept routine antibiotic use for prevention of disease. It's not about the science. It's about a moral judgment based on Twitter feeds, based on Facebooks. I'm not even on Facebook yet, and I'm glad because now I see if you're on Facebook, you're behind it anyway. There's something else new. I don't care. I don't have time to deal with my internal voices in my head, let alone Mom, and else. So, it's a funny world I live in. So, I think that this conference is so important because regardless of the science, regardless of the actual safety, okay, marketing people in these supply chains are like a rat that's been pushed too many times with a pin. They will do anything to not get poked again. That's what we're dealing with. And we need to continue our efforts to bring the science to it, to bring the efforts of how we do it, bring the fact to them that the MRSA that's causing disease in humans in the United States has nothing to do with animals. Documented that ST398 has lost its virulence factors for humans. We need to continue to do that. But understand there's a little bit of science and a lot of other stuff. You know, Chris says stuff. Thank you for helping me with my language, Chris. There's a lot of other stuff that's involved in that. So all these other things are incredibly important. So anyway, at least the pathogens are well described, right? So here's something that brings up just a little bit of controversy. This was the paper by Dr. Lubers and Dr. Hanslechek looking at 2009 through 2011 evaluation of Mannheimia hemolytica isolates coming through the K-State Diagnostic Lab. And I think Dr. Brumbaugh's talking about this tomorrow. So I'm really looking forward to that in the discussion. So basically, what they've reported, and the trend continues, and as I've spoken to people in other diagnostic labs, this is not just a K-State phenomenon. But if you look at 2011, about 35% of the isolates received at the lab that year were resistant to everything except ceftiofur. And if you look at the integrative conjugative element that's being described out there, it does not contain a third-generation cephalosporin resistance gene. Okay? It contains a beta-lactamase gene, but it's the first and second generation, not third. The other one, that's another 25%, is basically showing resistance to everything except fluorphenicol. So when you look at plus or minus for fluorphenicol, but including the macrolides, it's about 60%. So we get into the argument of whether or not you should use D-Lab data to cause us to be concerned. What are the odds that bacteria spontaneously mutated to resistance to about 6 or 7 antibiotics during therapy? pretty low. Whether or not that isolate was the primary driver of disease at the start in that animal, it's sure as heck there at the end. We can use some more help in looking through that. But regardless, this trend is troubling to me. It does not say that that's ubiquitous amongst high-risk calves. It says in the population of calves that gave enough grief that a veterinarian pulled samples and sent them in over the years, the proportion that are carrying phenotypic evidence of something like that ICE, the integrative conjugative element, is increasing. Talked about that. So there's what one of those looks like, where we're getting the R's down there. And yes, I do believe when you have an R that's been CLSI approved for respiratory disease for that drug, I do think it's not going to be effective. So that's a quick run through some of the things I think BRD is and isn't. I'm really looking forward to some of the other talks where people are going through diagnostic techniques, what might work, some of the larger epidemiological things. I'm looking forward to coming back through for resistance. But again, I'll reiterate, our challenge as the veterinary profession, well, we've got one real close, right? By December of 2016, the veterinarians in this room are going to be authorizing every feed and water use of antibiotics for their clients. I think it's a good thing. I think it's long overdue. I think the next thing we need to do is get Pen G out of the refrigerator to feed store, and it needs to be under your control. The number one caul residue, dairy cow caul residue drug, needs to be under veterinary control. Absolutely, you're the people that should be controlling that. Should put a little ball in the pit of your stomach about what we're going to do with the feed and those uses. But the real wild card is what's going to come through the supply chains. Legislative? Yeah. There's a little bit of a wild card there, but those things have been thrown at Congress and at committees repeatedly without really seeing much coming, but things could switch with that. So that thought in mind, I'll turn it over to the next ones and look forward to a discussion this afternoon. Thank you.